How about that? So thanks for coming today to this prescription drug abuse misuse grand rounds, which is held in combination with the college public health grand rounds. And I'm delighted that today we are able to host Miss Carla Saunders, who I'm going to read her bio here because it's so impressive, and it's important to hit all these high points because honestly, this is a national level expert that has been calling attention to this problem of neonatal abstinence syndrome and really helped trigger a lot of national attention on this topic in the past 3 and 4 years. So I'm going to read this bio because some important details here. So Carla Saunders is Advanced Practice Coordinator for the Pediatrics Medical Group at the East Tennessee Children's Hospital, which is not in Jackson City. This is not Nice Farmer Children's Hospital right over here. This is ETCH, which is in Knoxville. Okay? She is a neonatal nurse practitioner and a 24-year veteran to newborn intensive care. In June 2010, Ms. Saunders gathered a multidisciplinary team to handle the alarming rise of babies being admitted to the NICU with neonatal abstinence syndrome. They developed a standardized and holistic approach to the treatment of infants suffering from withdrawal created by maternal opiate exposure. The work done by her team is receiving local, state, national, and international attention. The team's work has been featured on CNN.com, Headline News, Anderson Cooper, ABC's Nightline, and ABC affiliate Australia. In 2010, she was named Advanced Practitioner of the Year for the Atlantic Region of Pediatrics Medical Group. And in August 2012, Ms. Saunders was honored as one of the great American country's great American heroes for her leadership in the neonatal abstinence syndrome at ETCH. This is it's a privilege to be able to hear her. That bio was read from the website of the National RX Abuse Summit, on which she is a board member. And so I'm delighted to turn it over to her. Before I do, though, I want to mention that in the audience you have a mix of prescription drug abuse working group members, cool. Some research team members on prescription drug abuse, some faculty members that do have this as a research area of interest, and some that don't. Okay. So anybody else? Did I miss anybody else? Clinical care providers from the region? Anyone? Yeah? I'm a physician from family medicine. Physician from family medicine? Okay. And a handful of others. So thank you guys so much for coming. And with that, Ms. Saunders.
Thank you. Thank you for having me, and I apologize. I have a wicked head cold, so if my voice comes and goes, and I'm going to try and truck through these really, really quick. So some of this, I think, hearing your backgrounds will be repetitive, but anyhow, we're going to talk about intrauterine drug exposure and neonatal abstinence syndrome today and how that affects us as a matter of public health. I have nothing to disclose.
Okay.
Yeah.
Should we do something about the lights a little bit?
Oh, I don't know. I can see this fine. I don't know about them. Huh?
Does that help?
Okay. All right. I just want to begin by reminding everybody that we have to remember that addiction is a disease of the brain. It is not a moral failure. And this is key to beginning to work our way through this problem, which is taking over the United States at this point in time from a healthcare perspective. And I urge you, if you aren't familiar with the process of addiction, to find yourself on NIDA's National Institute of Drug Abuse website, and they can walk you through some really beautiful pictorials of how this process works. Real quickly, we have tolerance, dependence, and addiction. Tolerance being that point at which where we're taking a medicine for postoperative pain and you have to take a little more after a few days to get the same effect. You're building a tolerance to that drug. Dependence comes in where you're taking it long enough, which for some people could be days, some people could be weeks, some people might be longer, that when you start to back off that drug, you begin to feel funny. You begin to feel mild symptoms of withdrawal. Addiction comes into play when you add that behavioral component. This is that part where a person will compulsively do whatever they have to do to get the drug. Putting themselves at danger, others at danger, an unborn child at danger, does not matter because the strength of that addiction is so strong in those pathways that it takes over. Abuse being the intentional, recreational, or unintentional, can be any of those. Use of a substance that does not conform to the social norms, and this can lead to addiction. Addiction, and this you could find more detailed at NIDA, is based on a dopamine pathway. It's a chemical catecholamine, which is a chemical neurotransmitter, sends signals to the nerve cells that are produced in multiple areas of the brain. This is where we have a reward response learning system, and this is where we begin to feel that feel-good feeling from whatever it is, that kind of heavy euphoric feeling. In the limbic system of the brain, these substances increase temporary levels of this dopamine. Things like natural triggers, food, sex, exercise, nurturing children, all can provide that same type of release of dopamine. Drugs activate the same system that's activated by the natural rewards, but they activate the system stronger and longer. They basically hijack the brain's dopamine system, and the brain becomes dependent on that drug. Natural rewards are no longer something that will fulfill that need and provide those dopamine levels to feel that pleasure. You have to have higher and higher levels to be able to feel that pleasurable sense. So after a while, the use of a drug leads to the adaptation in the brain, and the brain expects those higher levels. It wants those higher levels. And when you have a deficit in it, you are unable to feel that pleasurable feeling, even or except through excessive use of whatever drug you may be using. An example of how natural rewards versus artificial or chemical rewards activate the brain. You can see on these graphs, you can see the peak that we have in the dopamine levels from food and from sex, and then how it tapers off. And if you look at the peak and the duration for things such as amphetamines, cocaine, nicotine, and morphine, you can see where in this morphine group that it is a much more sustained, you have a longer duration of this feeling. So take a quick look at the epidemiology of substance abuse in the United States. NIDA suggests that we spend $600 billion annually in the costs associated with substance abuse. This includes all substances, so this includes tobacco and alcohol, which accounts for about half of that $600 billion. If you look at the cost estimators for the American Diabetes Association and the National Cancer Institute, those two combined barely make it up to half of that $600 billion. And so you can see those are two of the biggest, what we consider to be two of the biggest medical problems in our country. And those costs combined are hitting halfway about the cost of substance abuse in our country. A 2009 national survey on drug use and health revealed that 4.5% of pregnant women aged 15 to 44 will have used an illicit drug in the past month prior to delivery. I won't look at the Knox County statistics, but if you look at the key birth statistics from 2009, at just over 4 million babies, you can see that that would be approximately 186,000. And keep this number in mind because this 4.5% is going to come into play in a little while. Drug-induced deaths for this first time in 30 years, something has exceeded motor vehicle accidents for the #1 cause of accidental death in our country. When motor vehicle accidents became the #1 cause of accidental death in our country, we rallied together with a simple solution. We're going to force people to wear seatbelts. It's going to save their own lives, whether they want it to or not, and it's going to reduce healthcare costs by decreasing significant injuries and long-term health costs. So here we are now, we have a new problem. Substance abuse and overdose deaths are now the #1 cause of accidental death in our country. So we have to rise together and begin to look at this in the same fashion and see what we can do. If you look at the evolution of this, back in the 70s, this bar graph is the rate per 100,000 population of accidental overdose deaths. And so you've got, coming off of Woodstock, you've got, you know, a little right there about 1 per 100,000. And it stays pretty steady. You hit right around there was the heroin age, and then we hit the cocaine time period, which was in the mid-late 80s. And then you have this point in time right about here in the very late 90s, early 2000, where we start to see this spike. And about that time is when we began to put into play something, pain as the 5th vital sign, where we started to acknowledge that we are under-treating pain in the medical world and that we need to address this better. So what happened about that time was there was a drive to expand the use of opioids. There were studies done that were found to show that there was a less than 1% risk of addiction. There was a large campaign from the American Pain Society to use pain as a 5th vital sign. And then the 1998 Federation of State Medical Boards removed the regulations on the amounts of narcotics physicians could prescribe. Prior to that, there were restrictions. And in 2004, the Federation made, I'm missing a half of a word.
Only 3 left.
Okay. Made the treatment of pain punishable, and the under-treatment of pain punishable. So, you know, these are the things that speak to us in the clinical world, and, you know, when we're being looked at like this, we have to then change our practice. Joint Commission came in and said that there was no evidence that addiction is a significant issue when persons are given opioids for pain control. When you go back and look now, you can see that some of those studies are short duration, and several of those studies were backed by pharma.
I want to make one point. At least one of those studies was a qualitative study of a chart review with very few subjects. But it was a letter in JAMA, and it was purported to be an empirical study from JAMA, or New England Journal, I'm sorry. So yeah. it was misused by pharma.
Correct. So here we have how this paradigm of change of how we've gone from where we were in a place where basically opioids were reserved for end-of-life pain control and were certainly respected to be potentially addictive, to this complete and polar opposite switch. And so between revised guidelines, accreditation requirements, reinforcing pain assessment for hospitals, everybody has to address it. Every chart I write has to have a pain diagnosis. Even for a 25-week baby, I have to assess pain on that baby and document that I'm attending to it. And the pharmaceutical industry's pressure to prescribe has significantly changed the physician attitudes about prescribing opioids to treat pain. Dr. Thomas Frieden, the director of the Center for Disease Control, who I have had the pleasure of meeting through the National Summit, has stated that when he was in medical school, he was told, if you give opiates to a patient who's in pain, they will not get addicted. And he now says that's completely wrong. A generation of physicians are being trained that these drugs aren't risky, and in fact they are very risky. So for those of you who are looking at that education side of it, this is a piece that we really need to get back into the medical schools, the nursing schools. Any clinical pathway really should have a very strong program, I feel, in the science of addiction truly, and how that works, and exactly how dangerous these drugs can be. The president put together a national drug reform policy, and this is a few years ago, and there's already been a revised one in 2013. It was 2011 and 2013. And we were looking at things like prevention, expanding treatment programs, reform in the criminal justice system, and support of recovery and removing stigma, which is sure a whole lot easier said than done. If you look, what this graph represents is that the states that have the darkest green are the highest overdose deaths. And the orange dots, based from tiny to large, are kilograms of opiate. So you see that where the greater amounts of opiates are, the greater amounts of overdose deaths are, which stands to reason. This graph represents, and these graphs are from a report out of the National Safety Council from October of 2013. These rates are rates of your green, the bright green on the top, are your opioid sales. Your middle gray are opioid deaths. And your opioid treatments or admissions through ERs and hospitals is the big kind of beige group at the bottom. And that's from 1999 to 2010. So again, you can see the increase. Is it important to look at these things? Is it important to look at what do we need to do to rehabilitate, and is it cost effective? Because it is very complicated and it is very costly really trying to rehabilitate somebody. I'm not talking about detox, I'm talking about rehabilitation and getting them out there into a place where they're a productive citizen in society again. If you include healthcare costs and crime costs, criminal justice, all of that, for every dollar spent, there's a $12 return. And this is through NIDA as well. Breaking it down and starting to look at women, if you look at, these are deaths per 100,000 population, the black, of course, being the greatest and the white being the least. And you can see repetitively in these charts that Appalachia is always in the dark, is always in the high spot. There's pockets across the country, but Appalachia is really the epicenter for the United States for this problem, for the prescription drug problem. Also breaking down and looking at women, these are admissions to the emergency room for overdose, and the fine dotted line on the bottom is for heroin. And then you have antidepressants, benzodiazepines, cocaine, and the very solid bar where the red arrow points to is for opiates. And you can see, again, the steep rate of rise, and this is women. And again, I'm breaking it down to women because this is important for where we're going. When you look at women, you look at substance treatment among these childbearing women of childbearing age. It's interesting because SAMHSA did a study looking at women's perception of their need for treatment. And so your big red Pac-Man part of this is women who did not receive treatment for a problem and did not perceive the need for treatment for a problem. That's 84%. Of the women. 5% did not receive treatment but perceived a need for treatment. They wanted treatment, but there wasn't resources available. And about 10% is where we are with the group that knew they had a problem and wanted to get help. And this is out of 6.3 million women aged 18 to 49 in the year of 2007. So excuse me. So those are pretty astonishing numbers and percentages. Again, important with where we're going. This is a 10-care report that came out September of last year, and blah, 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 breaking it down into different things. The important things here are, this is the narcotic users rate per 1,000. Here you have The percent of women on narcotics, these are people who have been prescribed a narcotic who also have a prescription for a contraceptive. 18%. 18% of the women prescribed a narcotic have a prescription for a contraceptive. 82% do not. So there's a lot of room right here for intervention. Unintended pregnancy among all women and opioid abusers, again from same report. The general population has about a 50% rate of unintended pregnancies. Opioid abusing women have an 86.3% rate of unintended pregnancies. Looking at unintended pregnancies, these women are very unlikely to have no counseling prior to getting pregnant. It wasn't intended. They tend to have a shorter interval between pregnancies. They tend to enter into prenatal care late or not get prenatal care at all, and do not take their folic acid supplements, which is where we help prevent spinal defects in the baby. Women with unintended pregnancy are 60% more likely to have used cocaine within the past 30 days. 60% of women with unintended pregnancies. And we've already looked at how many women have unintended pregnancies. 86% of the women who are using a narcotic have an unintended pregnancy, and 60% of those are more likely to have used cocaine in the past 30 days. That's in addition to the narcotic that they're on. So prenatal care is something that is vital. This is an area that also is a place where we can intervene. It's kind of still not all the way upstream, and we're kind of backing up the stream right now. But it is imperative. It can define the difference between good and bad outcomes in a pregnancy. Even if a woman is on an opiate and is put on a medical replacement therapy, or is maintained on a medical replacement therapy, or is even detoxed, she needs to be under physician care. There is a lot of concern with this. Women are not seeking it because of the threat of legal consequences. They're afraid of being found out. They're afraid they're going to get thrown in jail. And frankly, there are limited substance abuse treatment facilities, which probably everybody is painfully aware of. So even if they want help, they can't always get it. And you know, there aren't anywhere near enough beds in this state. If we were able to get every woman that was dependent or addicted to narcotics, we couldn't find anywhere near enough beds for them. There just aren't enough resources. About 14% can find treatment. And there are really very, very, very few that are specialized to the pregnant woman who is on narcotics of some sort. Early intervention in pregnancy provides us a window of opportunity where we may be able to begin to engage a woman in looking at treatment and walking that path towards wellness. It creates a sense of urgency in some women to enter into treatment, to become abstinent, and to eliminate some of their high-risk behaviors. Not all, but some. And you want to grab those women that you can and engage them, and certainly not let this window close. The American College of Obstetrics and Gynecologists, their committee opinion is that physicians need to, or clinicians need to work with state legislators to retract and not put forth any legislation that punishes women for substance abuse during pregnancy, for the very reason that we want them to get prenatal care. Some of the sickest babies I have had have been babies who did not get, moms who did not get prenatal care. They delivered at home, they delivered wherever, they just popped into the hospital and delivered, and their term or their post dates, and they now are suffering from meconium aspiration syndrome and just horrid withdrawal, and the two are counterproductive to each other. When the kids are really critically ill, they need to be as calm as possible, and we can't catch them with sedation. I mean, I give enough to bring a grown man down, and I can't bring that baby down. So some of the sickest kids I've had have been babies who did not, moms who do not get prenatal care. This past summer, we passed through Children's Hospital Alliance of Tennessee, a bill by Senators Dung and Yeager, a Safe Harbor Act. And basically, there's a lot of blah blah to this, but the gist of it is that if a woman is pregnant and seeks rehabilitation treatment for her dependence or addiction prior to 20 weeks in pregnancy, she will not have her child taken away from her for that sole reason. If there are other reasons that make her or make her home an unsuited place for a child, that takes precedence. But if the only indication is because she was using drugs, then she will be protected if she seeks help and continues through with it. The other thing that this provides is some immunity for the physicians who are treating her, because there are a lot of people who are concerned about, we have a statute of limitations of 21 years, and there's a lot of people that, you know, are afraid that what we think is good today, we may find out is really was harmful, and that could come back to bite them. So there's a little bit of protection built into there. This is all fine, well, and good, but nobody knows about this. Everywhere I go, you know, women don't know about this. How's a woman who's in the middle of a problem with dependence or addiction going to know that this law exists? And providers don't know that it exists. So there's, you know, it's great, but we have a long way to go from here. And let's say everybody found out about it. Again, we don't have treatment beds, so there has to be some monies that are put into facilities where we can put these women. So what happens then? So here we have this woman who is using narcotics of one type or another, and this could be heroin, it could be you know, a prescription narcotic, it could be a prescription narcotic she's getting legally or illegally or supplementing. What happens is, of course, that mom is ingesting that drug. It's going through, she's metabolizing it, getting into her bloodstream. It goes through the placenta, the umbilical cord, and into the baby. And when the cord is cut, that baby's drug supply is abruptly gone. And so at some point thereafter, the baby will begin to exhibit some withdrawal symptoms. They are anywhere from some of these to all of these. They have inconsolability, high-pitched crying, which is, I can put a nurse in a room with two babies, one being stuck for an IV, one crying from withdrawal. She could tell you which one is crying from withdrawal. It's a piercing sound. They have horrible skin excoriation. They rub their faces to where their chins and their cheeks are just raw. They can rub their feet together to where they'll get blisters, and their bottoms will, if not protected and if the diarrhea isn't controlled, they will look like they've been dipped in scalding water and that their bottoms have blistered and bled. They have poor feeding. They can't organize their brain enough to stop and calm down and suck, swallow, and breathe. They will just thrash around a nipple. They'll be starving to death, and you'll put a nipple in their mouth, and they'll just keep rooting. They cannot calm down to form that suck around that nipple. So we have to tube feed them sometimes. They have excessive sucking. They'll suck on everything and anything that they can get their hands on, including, I found one baby with both hands up to their wrists in their mouth. Feeding intolerance. They vomit. They have a lot of vomiting and watery diarrhea, and profuse watery diarrhea. They also have sweating, which may not sound like much, but in a newborn that's extremely unique. Newborns don't sweat. They don't have that capacity yet. They have nasal stuffiness, which is not generally common. They sneeze, yes, newborns sneeze, but this is repetitive. They'll sneeze 3 or more times in a row, and then again in a little while they'll sneeze 3 or more times in a row. They have low-grade temps, and with that they have tachypnea or rapid breathing, and they have something called mottling, which is, you'll see in a second, it's a lacy kind of rash to the skin, but it's not really harmful, and it we don't think that it really hurts, but it's one more piece of the puzzle when we see that in combination with other things. These babies are also generally low birth weight. These moms are not always nutritionally sound. Some of the drugs, such as cocaine, can intervene with the blood flow to the uterus. It constricts the vessels, so you're not getting as good a blood flow, and that's what feeds the baby, and so the baby doesn't grow like it should. Small head circumference, which is small brain size, and that's key. Any baby that we have that's born with a small head circumference, for any reason, is at significant risk for developmental delays down the road. They have abnormal EEG patterns. We get EEGs a lot on these kids, and our neurologists can pin it and say, that it looks like withdrawal. They can even have seizures in extreme cases. They certainly have signs of physical dependency. These babies are not addicted. Despite everything that the media says, they are not addicted. They do not have that behavioral component. They cannot get up and crawl out of their crib and go grab the morphine out of somebody else's hand. So they are physically dependent. And it's important to understand, too, that our moms may be either physically dependent, they may be addicted, and they may not even quite be to dependency. They may just be using something for, a lot of OBs are giving hydrocodone for pelvic pain during pregnancy or lower back pain during pregnancy. And they're not really addicted, they're not really even dependent, but it's still going in the system, and the baby doesn't know the difference. These babies are very hypertonic. They're very tight. A newborn baby, when you pick it up by its hands, the hands should kind of like pull on you a little bit, but they're loose, and their head should lag behind like you think it's going to fall off. These babies, when you do that, they're so tight, and they come up like this in one piece. Their hips can be so tight that when I do this test to check their hips, we do on all newborns, and I rotate their hips outward, I can't rotate them outward without causing excruciating pain. Sometimes they're so tight the nurses have difficulty getting the knees apart enough to change a diaper. They have tremors, which can be very severe, and they can be mild. And then periods of irritability is an understatement. Yes, they can have periods of irritability. Generally, they're inconsolable. Sometimes they'll get to a point where once they're fed and diapered and they're swaddled, they'll calm down for a little while. But if you do anything, if you bump the bed, if you unwrap them, they startle and they just lose their minds, and they cannot. A newborn baby, if you they have a startle reflex, and if you startle them, they might cry, and they kind of throw their hands, and then they calm and bring themselves back to center. These babies cannot do that. This is not a good, because, it's not the best example, but it's the best I could get for video. Well, okay, play. No?
Click the player.
There it is. Okay. Oh, do you? They shouldn't arch like that. We finally got them calmed down. 30 seconds. He's almost standing up in the bed. is one that wore a blister into its heel from rubbing, kicking. Rapid breathing, panting kind of. And then what I'm pointing to there is, and I don't know how well it translates, but that's that modeling, the kind of red and white sneezing.
How long does this last, Carla?
This video or the
withdrawal?
Anywhere from weeks to months. Yeah, we're not finding a real good correlation between everything. There's a lot of unknowns. This baby should be, when I hold him over my hand, he should go limp. He should bend. He was planking. So, and he wasn't a bad one. Yes?
I'm curious, if all these symptoms are generalized, or are there any correlation with the kind of usage of drugs?
For opiate withdrawal? Mm-hmm. Yeah, things like some of the antidepressants, you'll get rapid breathing, you'll get some tremors, and maybe some irritability. That generally passes within a few days, and it's generally not this severe. The hypertonic, that piece of it, the extreme, the skin breakdown, and the vomiting and diarrhea, which I'm sure you're happy I didn't show. Those are fairly unique to the opiate withdrawal. And an opiate of any kind. It doesn't matter what it is if it's an opiate-based drug. We're also seeing a lot of things like Lyrica and the Neurontins and the gabapentins, and all of these things are all of a sudden being prescribed really freely in pregnant women, and the babies are having significant withdrawal from those. So if we know that's all we have and we don't have an opiate, we'll start with a different drug for treatment, but we often end up having to add morphine into it too. The thing about this is the immediate thing that happens. This is what's happening now. This isn't even looking into the future. This isn't even going down that road of arguing about environmental influences, etc. This is suffering that's occurring in the first days, weeks, months of a newborn's life, and not in some small quantities, in mass quantities that are increasing exponentially across the United States. And of everything that I treat in neonatology, everything, every disease process, every birth defect, there is one thing that makes this disease process different. This one is 100% preventable. If a baby is not exposed to these drugs in utero, they will not suffer through withdrawal. And we won't have to argue about what they may or may not be at risk for down the road. I can't say that about anything else that I treat in neonatology. We spend tons of money trying to figure out how to prevent prematurity, prevent birth defects, and go to great lengths to have, adequate nutrition and do all of these things during pregnancy to have the best outcome possible. Yet we are giving women narcotics, and we are creating this problem. And as we walk down the road a little bit, we don't want to do that again. And again. Well, okay, let's move on. Aha. So this is an article, Stephen Patrick, who's a fellow out of Michigan at the time, now is with Vanderbilt and working on several projects with us. He published this article 2 years ago now, I guess. He studied the incidence of maternal opiate use in NAS across the United States, looking at diagnosis codes, etc., from 2000 to 2009. And you can see that during that time there was quite an increase in both maternal opiate use, which translated into babies in withdrawal. What his findings showed was that approximately every hour a baby is born suffering from opiate withdrawal. Now these are the statistics then. That applies to those. Our rates have quadrupled since 2009. So that number's going to be a whole lot higher. Looking at hospital stays and cost nationally, these babies on with NAS had, during that time, 2000 to 2009, had an approximately 16-day stay. I don't know if that was to discharge on meds, what they were treated with, that I don't know. It's just how long did they stay if they had that diagnosis. And without was a 3.3 average day stay. With NAS, the cost was $53,000 and change, and without, $9,500. Significant difference in length of stay and cost. And you think about, we always talk about the maternal bonding, that time in the first hours, weeks. I mean, you know, some people are panicked if their baby doesn't get on their chest within seconds of the baby being born. Now you're talking about prolonged hospitalizations and disease processes which severely interfere with their ability to socialize. And so you're beginning to see that that sets them up for both mother and baby for issues down the road. I'm going backwards. This is out of the Department of Health, and this is the increase we see in Tennessee from 1999 to 2010 in NAS rates. And this again is not, this isn't gathered from the NAS reporting system that we put in place a year ago. It's from billing codes. The blue line here represents that point in time I was talking about where pain is the fifth vital sign. And boy, can you see where that starts to increase right after that. What have we seen? In our intensive care unit, we are a private, we are a not-for-profit standalone children's hospital, so we don't have any deliveries if we can at all help it in our facility. We have 152 beds with a 60-bed level 3 NICU. About 30, and that's on the low side, it's between 30 and 50% of our admissions annually are for the treatment of NAS, primarily for the treatment of NAS, not that and something else. This is a 35-week or greater gestation baby that's would have otherwise been healthy enough to go home had it not been in withdrawal. In 2008, I had about 35 admissions. 2009, it was around 45. 2010 is when we saw this problem just skyrocketing. And the middle of that summer is when we kind of pulled this team together. And then we started into our treatment program, and we are part of an IRB observational study so that we can take all the data we gather and use it. And so in 2011, we had 135 admissions, and 2012, we had 283. For 2013, we backed off just a bit. It was in the 256 range. And our highest daily census, that meaning the highest number of babies at one time, greatest number of babies at one time in our 60-bed unit that were there for the primary purpose of withdrawal, was 37. And that was in September of 2012. And you can see on the chart below the difference in the quarters. The first quarter of 2011, our average census was 8, and in the first quarter of 2012, it was 29, and it's holding steady right about there. That's about where our average daily census of NAS infants is. This is a bar graph, 256, I was close. This is a bar graph of our admissions over the last 3 years. You asked about how long they stay. 90% of our babies in our program have a length of stay of 30 days. That includes a 3-day watch time after they come off of their treatment. Looking for rebound, about 1% will require retreatment. We use a different drug if we have to retreat. 50% of the babies will get home in 21 days. 20% or so are very difficult to wean. They require multiple medications. Generally, 2 adjunct meds we use are phenobarbital and clonidine. We've moved clonidine up to the second-line drug instead of the third-line drug, just because there is some controversial literature out there now about phenobarb and long-term use of phenobarb in developmental outcomes. So there's just a lot of buzz in the neonatal world about it, so we've kind of moved this other drug up into the second place. And these babies have an average length of stay of 65. The longest stay I have for treatment is 155 days. And I just had a group of 8 or 9 from Chattanooga come through and asking us questions. Do we see this? Do we see that? Yes, yes, yes. And they are on a baby right now that they said was there 128 days. And that's their longest stay. And there's no hope in sight yet for that kid to go home. I think we've learned a lot, we've refined a lot of things, and that was earlier on in the program, and we haven't had a length of stay. We are continually decreasing that length of stay. What are the drugs we see? The tall, I know you can't read all of those, but the big one, the tall one, that's oxycodone. That's the #1 drug our patients are exposed to. And it goes all the way down to heroin. We have had some heroin. The 60-30 split there is polysubstance versus single substance. And that's as best we can glean from history and from drug screens. But none of that information could be considered 100% accurate.
Second one over hydro.
Yep. Prevalence of substance abuse among pregnant women. This is interesting because, of course, we all know that smoking, tobacco, is the #1 substance that is abused. And then the charcoal-colored one is marijuana. And so let's make that legal. And then I'm sorry, I'm interjecting my political views. Should do that. And then the teal, the next tallest bar, is opiates. So more information on what kind of drugs we see. In January of 2013, the health commissioner put in place NAS as a reportable disease. As the health commissioner in a state, he has the ability to determine that something is of a reportable disease nature. It is either something that is communicable, contagious, or epidemic. And he considered this problem epidemic in our state and decided that he was going to put in place, and man, when I tell you, we went from testing the report site starting in August, and we were talking about in August, starting the test site in October, and it was implemented in January. That's John. He got that, yeah, that's him. When he says, it's like, oh boy. Yeah, so it went pretty quick. A lot of, kinks along the way, and we're still working them out, and we know that the numbers that we're getting still aren't accurate because we still get calls that say that they have babies they know are withdrawing, the physicians won't either treat, or that they are not willing to put NAS on the baby's diagnosis, and so they don't report those. So we know that these are still not ideal. So we did that, and this is what the first year of data produced. The blue bar graph is the number of cases last year, and we ended the year with 855 cases for the state. The green line is an estimate for 2011 based again on diagnosis codes. Again, it's just the best estimate they could have to have some sort of starting point. And last year, 2012 data wasn't available. The other thing, it's only like 5 or 6 questions that people have to answer, but we're looking at county of origin of the mother. Where does she come from, so that they can know maybe where they need to put more resources. And East Tennessee, 28%, yay, we're ranked right up there, is right on top. We had basically 0 from the western part of the state, but we now have, in the Jackson-Madison area, we have 2 cases. It is primarily a Caucasian problem. About 98% of the women are Caucasian, and the western part of the state tends to have a different demographic, and they think that's why, because there was a lot of question as to why doesn't the western part of the state have this problem. That's one reason, but you also have to be looking for it, and that's the other problem. The other thing we look at is where they get it. And so the key things here are that 46% of the cases are supervised replacement therapy. These women are in some kind of program. 39% are prescription substance that's been diverted. someone's using it without a prescription. And then we have 30% that are using a non-prescription substance, and 20% that are in supervised pain therapy. So again, you can see most of these drugs are being given to women by physicians.
Can you go back one slide? I want to point out, these are not population norms, so, or what's the word, population-based stats. So it's East Tennessee probably has far fewer people in it than the national population, for example. Right? The Davidson. So it'd be, at some point we need to figure out how many people are in each one of these regions and do a population.
I did that when I was preparing that grant. If you count Northeast and Sullivan, which are our 8 counties, 8% of Tennessee's population, we have just about 25% of the babies.
And probably Knoxville area, Knox County is probably, 8% as well.
We had 25% approximately of these newborns.
Yeah.
Yeah, and we have about the same.
Yeah. Yes.
Yeah, are these percentages mutually?
I'm sorry?
Are the percentages mutually exclusive, or is that on the medication so many
Are they mutually, the medications, are they mutually exclusive? It's not that, they can be on, that's why the numbers add up to greater than 100%. No, they're not mutually exclusive. They were trying to get something just started, I think, to call attention to the problem. This is public information. You can look it up on the Department of Health's website. And I think it is an attempt to begin to show, other clinicians that this indeed is a really big problem. And, there's the proof in the pudding. Rarely is it mutually exclusive, even when my best evidence says that it should be mutually exclusive. And then this is just more of what's on that website. I won't go through this, but it's a breakdown with really good information of what that looks like. So if you take the current TennCare costs, what does it cost to treat these babies in our state? For those people that, might be out there that so I heard a woman say, an OB on NPR say, that it's really, we're making a big deal out of this. It's not that big of a problem. It's an easily treatable disease and there's no long-term effects. So if the suffering the babies are going through is not enough to tug you into action, this might be. A healthy newborn in the state of Tennessee costs around $4,000 to take care of. A newborn with NAS costs almost $67,000 to take care of in our state, and this is recent. This was reported in 2013. So if you take the 855 cases last year, that's what it cost our state to take care of those babies in 1 year. And if I didn't mention before, this is 100% preventable. Now, people will argue with me about that. Yes, there will always be situations where something happens to a mom and she has to be placed on some sort of opiate during pregnancy, or there's an unintended pregnancy. And so we have to function on we've got to look at all aspects of this. But the bulk of this really is where we need to put our efforts, is in this preventable piece of it, into the primary prevention piece. Why are mothers using? They've either had prior injuries or chronic pain. They may be appropriately or inappropriately managed. They may be in a treatment program. They may be confused about the signs of withdrawal if they, are going between money to buy and now they don't, and they're going through, binges and purges, so to speak. They may think that what they think is, oh, I need another fix because I'm feeling nauseous and tired and all of these things. They may actually be pregnant, so they can easily justify away that they're not pregnant. And their menstrual cycles may not be regular enough for them to really even identify. And then family social environment. Oh my God, when you hear the stories of these people, it's horrific. It's horrific. And that's when you have to remember that nobody starts the day wanting to be an addict. Nobody. And some of these women were probably NAS babies themselves, number one, and as well were being given pills to take at very young ages to either make them sleep so that somebody could party or somebody could abuse them. And so this is a very complicated dynamic. The drug source may be legal or illegal, it may be diverted, may be used as directed, misused, or abused. The baby doesn't know the difference is the point. The baby doesn't care where the opiate came from or why. It's going to have the same effect on that baby either way. It will affect the brain development and affects are dependent on gestation and drug exposure. Specifically, do we know yet? No. Why do the docs continue to prescribe? Well, because as I said before, our governing body, ACOG, tells us, and SAMHSA tell us that the best choice for a pregnant woman is to be maintained on a medical replacement therapy. You want to prevent her from detoxing and then relapsing. And the baby's gone through detox, then mom relapses, now the baby's high on God knows what. She's probably embarrassed and hiding and may not go back to her treatment, and she may now be desperate enough to go into other behaviors that she wasn't utilizing before. She may start buying off the street, she may start shooting up, maybe she wasn't shooting up before, and so the idea is that once you find yourself pregnant and in this position, the best place to be is with solid prenatal care and with good, real, not methadone clinic, real replacement therapy program, a rehabilitative program, not just a pill mill. I say methadone clinic, I mean a pill mill, where they're just walking in and passing the pills out like candy. They need to be in a program. Again, ACOG's standard of care to refer them and to keep them on those medications. And then they also make a statement that during the intrapartum postpartum period, special considerations need to be put into place. They need to be looking at postoperative pain management on these women. They need to be looking at preventing relapse with that postoperative pain management, risk of overdose, and ensure adequate contraception so this doesn't happen again. But this is a real problem because we have some payors out there make you wait 6 weeks before you can have your tubes tied. These women aren't going to come back. And they may want their tubes tied, but the physician can't do it. I've had that told to me by physicians time and time again. She wanted it, I wanted to do it, but I can't. And because she may decide later she wants to have another child. And someone I was speaking with last week said, you know, if that woman tells you that she doesn't want to have any more kids, she probably knows better than anybody why she doesn't. So she should be allowed to have that freedom. We need to remember the intrauterine drug exposure in the presence or absence of neonatal abstinence syndrome does not indicate the severity of the intrauterine drug exposure. A woman, I have seen a baby that came in for observation because the mother left it AMA. She came in high as a kite on cocaine. She took every drug she could get her hands on. We watched that baby for 2 weeks. It never went into withdrawal. I had somebody at the same time that came in on a very low dose of methadone and was in a very legitimate program and was on her way to recovery, and her baby had horrid withdrawal. And so we don't know what those different factors are, other than there may be some genetic links that make it more make them more susceptible. The key here is the brain is the first organ to develop. At 2 weeks, you see the brain beginning to develop. By 12 weeks, the majority of that brain development has occurred. And in there, we have things such as sensory. At 8 to 9 weeks, we begin to experience a light sense of touch. And that continues to develop. We're seeing a lot of sensory disorders in these children, so we wonder if that might be something that's being affected by early drug use in this time period, which at that point in time, for many of these women, may be multifaceted because they may not be in any kind, they might not know they're pregnant and probably aren't in any kind of medical care. There are neuroimaging studies that show that there are brain changes in drug-exposed infants versus non-drug-exposed infants. These are in the temporal lobe mostly. That temporal lobe is where we make our decisions. It's where we have addictive processes that can begin, and these are permanent and can't be fixed. Nurturing can, however, environment and nurturing can mitigate some of these damages, but you can talk to foster parents, very strong foster parents who have had adopted these children, and they still have significant problems. This is a picture of the brain volumes. The one on top is no exposure, and the one on bottom is Lortab use during pregnancy. These are Henrietta Botta's out of Louisville. Long-term effects, brain development is affected, SIDS, sleep disorders, neurodevelopmental delays, behavioral regulation, sensory processing, cognitive learning delays, and there are lots of psychosocial implications with this. Other drugs also do play effect. It's not that opiates are the only thing that affect the brain, but there is evidence that any of these drugs will affect behavior later. And Dr. Nora Volkow, who is the director of the National Institute on Drug Abuse, has said that addiction is a developmental disorder of adolescence, where a person begins to become addicted at that age is where their developmental brain becomes stunted, so to speak. So then you're dealing with that 15-year-old mostly their whole adult life, or you're dealing with that 12-year-old mostly their adult life. So then their even abilities to make good decisions is changed. What we're seeing is really just the tip of the iceberg of what's going on with seeing the numbers of these babies. It's astonishing, but it's just the tip of the iceberg. There are significant public health care issues, NICU beds taken by infants whose only need is withdrawal treatment because we have nowhere else to treat them right now. There are behavioral issues in childhood. We have potential long-term health complications. We're concerned about the generational addiction issues. We're concerned about these genes being activated in utero. We're concerned about our treatment. Is that further contributing to it? And what will happen down the road when these pathways are exposed to an opiate, either through recreational use or through some sort of surgery, and that child's an adolescent or a teenager and it runs across an opiate for whatever reason. Will it ignite that just like that? Things that we're doing in our state, there's the Tennessee Initiative for Perinatal Quality Care. We have a statewide NAS group that is working on a toolkit for treatment and looking at things from the treatment aspect. Department of Health efforts in Tennessee. We've got the Prescription Safety Act. We've got the Controlled Substance Monitoring Database, growing awareness. They've got a cabinet-level department looking at both substance abuse and neonatal abstinence syndrome. And there's an opioid prescribing task force, which it was really cool to be part of. And the commissioner told us to be bold when we were writing these guidelines. And they're going around the state now and kind of being presented to clinicians, and I know there's going to be pushback, but this is where we are. This is the world that we live in. Another state that has done this is Washington, and you can see the time frame, point in time where they put some prescribing guidelines in place, and then the beginning data they have to show decrease in overdose deaths. There's a NAS Research Steering Committee, which I'm part of, and we're looking at identifying 5 potentially answerable questions around NAS, which those questions have been identified, and now we're trying to begin that process. It'll take a couple of years for some of that information. Levels of prevention at the primary or at the public health level. You've got primary, secondary, and tertiary. This is a great one for primary prevention. What we have now is Tennessee helped contribute to letters to help kind of push the FDA into a black box warning on these narcotics, which we got. We are looking at things like provider education. That is a great way. Providers need to get the education that there are problems, because I hear time and time and time again, my doctor told me the baby wouldn't have withdrawal. My doctor told me it'd only be 2 or 3 days. My doctor told me there's no long-term problems. And I don't feel these physicians are lying. They're going on what they've been taught. Now we have to figure out a way to reteach. There is a requirement for counseling as as part of prior authorization for TennCare for these narcotics. And then looking at things like universal risk assessment and urine drug tests. There was a time when HIV testing wasn't universal. And it was kind of, do I do this on my patient? How do I approach this with my patient? And we got over that. We made it universal because it was in the best interest of the public health to identify people early and to stop the spread. And so we need to come to a place, unfortunately, where we are doing risk assessment. We as clinicians in every avenue are doing risk assessments anytime we see a patient. And if we're having them come into our office and pee in a cup for urine for any other reason, they should be getting a urine drug test, because you can identify somebody early that may have a problem. And that's what we need to begin to do. This is the news release from the FDA on the black box warning. This is what the TennCare prior authorization form looks like. It's for females between 18 and 45, and it asks, are they using a form of contraception, and if they're not, have they been offered contraception? Also, looking at that, preventing pregnancy from occurring, looking at provider education, and talking about initial counseling prior to prescribing a narcotic, talking to them about the risks of being on a narcotic while they're pregnant, promoting long-acting reversible birth control, and working with non-traditional partners. The alcohol and drug programs, pain clinics, the drug courts, which we are out there trying to work with, and to promote counseling about the potential, issues. And the fact that we don't have any solid 20-year long-term longitudinal studies is not a reason to just assume that there's no long-term side effects. Anybody who looks at the pathophysiology of the brain and thinks about the exposure has to be able to conclude that there is at least a potential. At least a potential. And if there is a potential, we should be doing something about it. Secondary prevention comes into play when we identify pregnant women who are now in that place. They're pregnant and they are opioid either dependent or addicted. So we want to identify those women in the OB offices. The OBs have to get to a point where it's standard practice and they're not singling out their patients. I had an OB yesterday that has been locally. He is one of the, private pay patient gurus. He's fabulous. He insisted he does not have this population, and baby went. There was nothing to indicate that there was an issue till the baby started to go into withdrawal. And you clinically, when you see it enough, you know it when you see it. It is a clinical diagnosis, and this baby had it, and we are now sending over at Fort Saunders cords on all we collect cords on all babies. That cord got sent off, and it was positive for oxycodone. And on interview, the tears, and she has a problem, but nobody knew it. Yes.
When you identify these pregnant opiate-addicted patients prenatally, are you advocating detox and abstinence or maintenance through delivery?
Well, I don't treat. I'm neonatal. That is the question. I would love to get a chance to have this discussion with ACOG. Their most recent statement was really soft, and I'm not quite sure why they're so far behind on this. I think.
Anybody in the Knoxville area doing detox?
Yes, Helen Ross McNabb has 12 beds. 12 beds, I think, maybe less. But we have a few places that will detox. Mm-hmm. Yeah, but there's very few out there.
There are people around here doing that.
Yes.
Yeah.
I've had a few babies that have been through detox, and they still withdraw, which is something I can't explain either. I mean, they're fine day 1, 2, 3, and day 4 or 5, they start going into what appears to be full-blown withdrawal. And everything I can tell, they've been off drugs for, even 3 months. So, Anything, yes, maintenance drugs, or I just stopped on my own, but I'm talking about the ones that are in a program, and the doctors are calling me saying, I've got the negative screens and she hasn't taken anything. I can't answer it. I can't answer why they're still showing withdrawal. Tertiary prevention is looking at minimizing the complications for women who are dependent and addicted. Can they be weaned, and what are the best treatments for the babies, and that's what we're looking at trying to identify. Key points to remember is that NAS does not end in the NICU. There is a long-term impact to both the healthcare system and society, and it is significant. These children cannot function in school, and these are the kids that are now coming in droves. I hear it. I've spoken to Head Start and to the school systems, and I mean, the teachers are just tearing their hair out. They don't know what to do with them. These children cannot learn well, and we've got to identify these children and help them as best we can. We've got to look at preventing unintended pregnancies. Excuse me. We've got to promote the prenatal care and make it easier to obtain for women, and we've got to incorporate into that supervised medical replacement therapy until that question of detox or not, whatever, is answered. And we absolutely have to do everything that we can to promote these things in this population, looking at what incentives might we be able to put in place, and looking at not just detox and these 7 and 21-day stays, but we really have to start looking at the holistic part of this. We've got to help these women get out from where they are, learn new skills, find new housing, get a job. Not an easy task. Isn't it so much easier to spend the money on the front end and be the physician who finds the problem early on before a person has too big of a problem, before they enter down that road? Because it's really, really hard, and it is a lifelong battle. They will always have that battle. Did I mention this is preventable? So one of my favorite people, he said we cannot solve problems with the same thinking we used when we created them. And I think this is really key. We can't stand in the box that we're in and solve this problem. We can't say, oh, I'm not going to do testing because insurance isn't going to pay for it, or I'm not going to do it because there's no treatment for these women. So that's a reason not to find out. I mean, we've got to start, we've got to get our heads out of the sand, and we've got to come out of the sandbox and start problem solving from a different viewpoint. The other key thing about this is not something that can be solved from silos. We cannot arrest our way out of this. We cannot detox our way out of this. We cannot shut down pill mills our way out of this. This is a multifaceted, every aspect of our community and society. And so everybody has to take the piece that they own. Everybody has a piece that they can own and has to do what they can within, where they are, and we have to work together on this one. And I put this up there because this has been a unbelievable journey the last 3.5, 4 years, and it gives me strength. And innovation or any new idea by definition will not be accepted at first. It takes repeated attempts, endless demonstrations, monotonous rehearsals before innovation can be accepted and internalized by an organization. This requires courageous patience. And I think that's real important, because trying to tackle the American Medical Association and ACOG and nursing and all of these great entities and really get in there and tell them that we have to change, that's a really big task. They want that. They want those long-term studies. They want those double-blinded controlled studies. You can't ethically do that with this population. I can't do that. That's the reality. That's not a reason, because you don't have that information, is not a reason to not take this on and say, oh, it's not a problem. Logic dictates that and we're seeing through the numbers that it is a problem. So with that, I conclude. My contact information's on here. I also have cards. If you have any questions, I'll be happy to answer them. And I apologize for talking so long.
No. Folks, before you leave, let's ask some questions really quickly. And before you leave, I gotta get you signed in. Did we do a sign-in sheet? Is there one's gone around?
One's
perfect. All right, good.
Also, if you're here for the ACC and we credit, I need to sign separately over there. But that's about it.
Any questions for Ms. Saunders?
Do you have any advice for students who are graduating in May, like what we can do to make a difference?
Where are you graduating from?
From here.
I mean, in what school?
A Master's of Public Health. I just wanted to.
Oh, yeah. Well, advice, I don't know, but I know there is plenty of opportunity. And I think it's going to take innovative young minds to be brave enough to think outside that box and to present new ideas about how we can go about primary prevention. And you will get shut down. You know, you will get shut down, but you have to keep going. And I say that because it's the people who are coming out that are you know, haven't been in the trenches as long, that have a little more energy to keep getting up when you get beat down. I wholeheartedly believe that there will be a day when urine drug testing, I think I took those slides out, unfortunately. Drug testing and drug screening, you need to look those up. They're two different things. Screening needs to be thrown away. It really has very little. There's some place for it, but within the medical community, we need to be having metabolite testing. We need to know what we're looking at. It can't be fooled. But I think, you know, we've got to accept that this is a public health issue. This is a #1 public health issue. Think about all the people who have a problem, all the other healthcare issues they're having. I mean, to me, right here, this one single thing, if we worked on it, would make such a huge impact on our healthcare. I mean, you know, it's my healthcare reform policy. Because it does. In the adult, it plays out, and in the child, it's playing out. And so, you know, I think looking at those prevention pieces and looking at what you can do from education standpoints, you know, I mean, there's plenty of, there's education of the community, education of, you know, care providers. There's certainly looking at education about contraception, and it, you know, that's a heated subject, but we have to tackle that too. You know, we have the data. We have the data. And, you know, I mean, if a person doesn't want it for their religious beliefs, that's one thing. But there are plenty of women out there that would preferred to have prevented the pregnancy.
You need to get involved with our drug use research team here, because there's some people that are part of that larger working group that are beginning to tackle this NES problem in this. Other questions, other thoughts? Well, go ahead.
I noticed that in your title you talked about intrauterine drug exposure, and we're starting to get a handle on the NAS. What about the exposure part?
That's my point. I think, and that's like, as we got into this with just literally, we're being overrun by babies and don't know how to take care of them. And to here, right. So we started here, and then, you know, moved on from there. And, you know, the American Academy of Pediatrics would say that you need to watch anybody with no prenatal care, any history of drug use in the past, a positive drug screen at all during pregnancy or on admission to the hospital. You watch that baby a minimum of 4 to 7 days. Babies are going home at 24 and 48 hours. And we're working with third-party payers who are now, I mean, we keep them in our facilities and we're not getting any pushback. And, you know, we're observing them, and that's part of why our numbers have gone up. So you don't know you have the problem as bad until you start saying, well, maybe I should be following these guidelines, and you put a policy in place, and then all of a sudden you start seeing that a baby that looks completely normal on day 2 can be completely out of their mind on day 4 or even day 10. So I forgot what the original question was.
Okay, it's just about how many, whether
Oh,
it's an even bigger problem because we're not capturing.
Oh yeah, that's the point, and that's why.
Rise to.
Right, and that's why we backed it up. Now we started trying to wave the flag about the babies, and then we started realizing that it's not just about the babies who are withdrawing, because that's horrible, but we're panicked about the intrauterine drug exposure because, you know, I quoted how many babies are withdrawing. I didn't tell you how many babies I have that aren't there for withdrawal, that are preemies or there for another reason, who also had a drug exposure. They're just not able to exhibit, you know, the signs of it yet. So, you know, it is that drug exposure that really frightens us about the pathways of the brain in those first 12 weeks. And if you interfere with those pain pathways during that time, can that have a lifelong impact on that child's fight to stay away from addiction? We know that uncontrolled pain in an infant, there are studies that show that if an infant is not given pain control, that will alter their pain pathways. So if not giving them something can alter it, and while it's developing, if you're exposing it to these chemicals, I just don't see how you can logically say it's not a problem or not potentially a problem.
Particularly given the hyperalgesia we know comes from chronic pain management.
Yeah.
Other thoughts?
Yes?
So when you report to the state, do you report only the babies who get replacement therapy, or even the babies who you watch for 5 days and did not get withdrawal enough to
The state reporting system is if you diagnose a baby with NAS. And generally, the referring institutions that refer to us, if they diagnose it with NAS, it's needing treatment. Otherwise, it's an intrauterine drug exposure. And so every baby that I see that has an intrauterine drug exposure as a newborn, they have that diagnosis on their chart. If they go into withdrawal, then they have NAS. The TIPQC, which is a big collaborative in the state, they have a little more in-depth kind of project, and it's a voluntary participation, but it is being widely participated in across the state. But we are looking at that in that group. We're looking at are they who is being watched and how many are not requiring therapy. The AAP says that 55 to 94% of babies exposed will develop withdrawal to the point of requiring treatment. That's not to say that they don't have some withdrawal at all. It's just to the point of requiring treatment. I took those slides out, so, but yeah.
Carla, thank you so much.
You're welcome.
Yeah, it's been fantastic.